need to focus on the bit that you're looking at, whether it's the brain or the heart or the liver or the pelvic organs, rather than trying to do head to toe. You're not going to get the same resolution. Everything's split.
Yeah.
So the brain will take 15 to 20 minutes.
Yeah.
The cardiac will take 15 minutes.
Yeah.
If they have an MSK, it might be 10 minutes.
There is Kim Kardashian taking, I don't remember if there's this selfie or like a picture saying, you guys, you should try this MRI scanner, this whole body MRI scanner. Also say funny things about confusing CT, MRI and stuff like that.
Kind of like servicing your car. You get your car serviced every year, and if there's a small problem, they'll point it out and then you'll get it fixed.
And of course there's a lot of pushback and controversy, and I see that you guys separate yourselves from that perspective in a way that you do a full body assessment.
We may tell you that there's this cyst or there's this finding, but will be extremely clear to you to let you know if it's something significant, if it's something you need to act on, or if it's something that you can completely forget.
Most of the population are afraid. They're like, oh, I don't want to do a scan. I don't want to find anything that I'm not ready for.
The process of starting your preventive medicine journey is probably the most important thing. Being aware of your health, aware that you want to try to optimize things.
The rate of cancellations was so high because people were like, oh my God, I'm stuck in here.
A client can lie there with the mirror, it's a huge mirror, and watch a screen on the back or watch Netflix. Most of them come not expecting us to find anything.
One of the topics that is probably gathering more momentum these days is actually preventive medicine. And I think not only from us as healthcare professionals, but also from the patient side. Patients would like to know more why preventive medicine is becoming so important and the role that it can play. So I think we can be very glad to have you here today, Ying and Matt, to discuss about this. So Ying, do you maybe want to start first and tell us a little bit more what's your relationship, your background, and how you dive into preventive medicine?
Sure. So really nice to chat with both of you today. So my background is as a GP. So I trained as a GP, and obviously through what we do as GPs, there is a lot of preventive medicine built into that already. But I became much more interested as I started my practice and gained more experience as a GP, and then probably transitioned and shifted more to really focusing on preventive medicine, doing health assessments, both working in the NHS, but also as a private GP as well. And then in terms of where I work at the moment, so Preventicum, where we do preventive health assessments, I've been there for 3 years, and in my role as the medical director for the last 2 years now.
Perfect. What about you, man?
What about me? So I'm a radiographer by profession.
Perfect. You're one of us.
I'm one of you. One of the brothers. So I qualified in 95. I left the NHS to work at Preventicum in 2005. Saw an advertisement for a new startup health facility that caught my interest. So I've been there since 2005. I've been imaging services manager for the last 10 years, I think. I still did some work in the NHS from 2010 until probably about 2 years ago. So I was still doing some MRI down in Kent. Just keep in touch with what goes on within the NHS and some of the other imaging sides of MRI that we don't necessarily do in the clinic that I now work at.
Was the preventative medicine something that attracted you straight away to this job, or there was something else back then?
I think I was a senior rad, and the advertisement was for a lead, so it was more about career progression.
Fair.
And I went for the interview not expecting to get the job, or be offered the job. So it was quite a dilemma when I got offered the role. Almost like, okay, I got to make a decision now. Because the NHS is quite a comfy place to work.
But how did you get ready for the interview? You were like, okay, now I need to kind of like explore a little bit into this word, or you're like, no?
I think I just kind of winged it.
Yeah.
I didn't know what to expect. It was something quite new. And I don't think I really knew what it was until I was sat there being interviewed. So it was a new venture. I was, I think, their first medical person that they employed.
Oh, wow.
So when I started, we didn't actually have a clinic. So it was a bit of a shock to start your first day in an office
patients,
without, no scanner, no clinical environment, and then sort of setting up.
So you basically were there building it.
I was a guinea pig, yeah. A guinea pig, I think.
So it feels like we're talking about something esoterical here. So what exactly are we talking about? So it's Preventicum is doing some kind of protocol, I would say, for preventative medicine. Is there a way that you can explain that step by step so people at home can understand what the conversation is about and then probably go from there? I don't know if you want to...
So what Preventicum offers is really very detailed health assessments, which are aimed at helping to prevent disease, but also to identify, hopefully, the early stages of something. And that could be heart issues, it can be cancers, risk of stroke, and lots of other conditions. And the whole principle is that we do our assessments in our clinic, and everything is completed in one place. So everything is in-house. People come for a day, so it could be around about 6 to 7 hours that they're with us, and there are multiple things that person will have in one day. And I think what's important is that although we're very much imaging based, everything is still doctor led. So we have GPs, and the pattern of a day for someone will be that they will come in, they'll have basic observations completed, they do things like body composition, they do a full set of bloods. And
you have in-house lab as well for those?
We don't have an
labs?
in-house lab. We have a lab partner who's probably the biggest private lab in London and probably UK. So we have those couriered to the lab, and there's a very fast turnaround time for the results. Because what we try to do is to complete the tests on one day and have the vast majority of the results back on that same day, so that we can give feedback to what we call our clients on the same day, so that they know for certain by the end of their assessment where they stand. So hopefully they're going to be completely reassured. But if there is anything that needs to be highlighted, then it's highlighted to them on the day. They're given support and advice on where to take things. I think that's important, and that's where the importance of it being doctor-led, because you have an hour-long consultation with a GP, with a dedicated GP at the beginning of the day, and that goes through all of a person's current worries. So if they're worried about specific conditions, or if they're having any current symptoms, family history obviously is important in terms of risk factors. They do an examination, and then that same doctor sees them at the end of the day to summarize all of the results. So it's trying to tie everything in to that one day, and not to leave anything left open. So I think that's probably a potential risk.
Very structured process.
Yeah. So it's structured in that way, because we want people to be comfortable by the end of their day. And that's, as I said, knowing that everything is fine, which is invariably the majority. But if there is anything that's detected, then you have that conversation face to face on the same day. People know where they stand, and they get the appropriate support.
So are these patients assigned a physician when they get into the door? And because there's a big psychological component when someone gets through that door thinking, I'm going to be here for 7 hours doing all these tests. Most of them probably are hypochondriac or claustrophobic, or they're afraid of something, they have history and family. So how do you accompany the patient throughout the whole day? Is there one person that actually guides the patient through all this process, or they just go from room to room?
So I guess it might be helpful to explain the setup of the clinic. So in terms of before the person comes, they either are assigned a specific doctor that's going to be looking after them, as in their overall care for the day, or they actually choose themselves. So we're very transparent on our website and all the material that we have, and we have a full list of doctors and GPs and with biographies. So there are certain doctors who might subspecialize in certain things or have a specific interest, and that might be completely irrelevant to.
So if a patient, for example, comes already with something in their mind, I might have some problem with my heart, they can just go to the list and choose that specific kind of doctor that is more dedicated to their...
So potentially, whatever the concern is, there may be something in the biography that resonates with them, which means that they're more likely, or they feel that they're comfortable to go with them. They have their own room. So each person that comes to us has their own dedicated room. That's their own private space. So that will be the space they go to in between tests, where they have lunch, potentially where they have their results consultation as well. So they have that kind of dedicated private area as well. They're not accompanied as such by one person throughout the whole thing, but they are taken to each of the different tests, and we have a big team that will do that. And also, for example, if someone went from MRI, then Matt might guide them to ultrasound. So there's always someone who's taking them to. There's a pathway. There's a pathway. They get to know our team very well on the day, and we try to make things as comfortable as possible in terms of the environment. Cater to any specific needs that they might have. If they need to take certain breaks, then we try to incorporate that as well.
Matt, we got a plethora of MR techs, MR radiographers back home, and I guess someone might wonder, okay, but in terms of MR scans, from a technical perspective, is there anything different? Is there like any specific sequence, I don't know, that you run more frequently than others? Or is the scan quicker? Maybe because it's like preventive medicine, we don't look at anything like...
I mean, we do a standardized set of sequences for each body area, depending on the assessment that the client is paying to have done. They all incorporate brain MRI, full brain MRI, with our higher spec checkup. This includes brain key. So we do additional scans that are sent off to be analysed, and then we get a report back from them. We do cardiac MRI, which doesn't involve contrast.
Yeah, this is quite interesting, I think.
Yeah, we used to do late enhancement with contrast years ago, until there was the worry about residual
gadolinium on the brain. Yeah,
exactly that.
Yeah,
I'm glad you remembered. So we moved away from giving contrast, and now we just do T1 and T2 mapping.
Yeah.
Plus we do a thing called OSCMR, where we stress the heart, hyperventilate, and then look at the effects post hyperventilation to see, using T2 star to see how the myocardium reacts, looking for micro or macro vascular changes.
Do you do this for all the patients, or
just for the certain checkup that we offer?
Yeah.
The more higher spec checkup that we offer, and that adds about 2.5-3 minutes.
Yeah.
To a standard cardiac MRI. So we'll get them to get them to hold their breath, do a scan, it's a 3-minute scan.
Yeah.
But that incorporates a 10-second breath hold, then
of course
60 seconds of hyperventilation, then another breath hold at the end where they try and hold their breath for at least 45 to 50 seconds. And then this gets sent away and analysed, and then we get a report back. The other thing we do is MR abdomen and pelvis, that also incorporates liver multiscan, where we look at the liver for
iron, fat, and fibrosis information.
So I will ask something regarding that, the MRIs that you're talking about, because there's a lot of conversation nowadays about the whole body MRI, right? So there's some companies out there just selling the whole body MRI protocol, and a person just jumps in the scanner, has a full scan, comes out, and of course there's a lot of pushback and controversy. Yeah. And I see that you guys separate yourselves from that perspective in a way that you do a full body assessment. It's not a full body MRI scan, it's a full body assessment. Can you both go through a little bit? Matt, you telling me that you do this kind of scans? I believe there's
we've looked. We've done lots of, we've tried different things in MRI. So we've done AMRA, which looks at body fat.
Yeah.
We've moved away from that because it doesn't offer anything more than body composition machine, our in-body machine. Yet it would take 15 to 20 minutes to scan them from neck to mid-thigh, It didn't add anything. It just meant that they were in the scanner for more time. MRI is not CT, so you're not going to get the same resolution if you're scanning head
The whole
to
thing,
toe,
yeah.
as opposed to
With larger
if you do a
FOVs, of course.
dedicated brain MRI, you're going to get more detailed images of that particular area. With MRI, you need to focus on the bit that you're looking at, whether it's the brain or the heart or the liver or the pelvic organs, rather than trying to do head to toe. You're not going to get the same resolution on the same detail. It's not CT. So we focus on the key areas like the brain, the heart, the abdomen and pelvis. For the men, we'll do prostate, which is something we've introduced this year, prostate screening. We work with Heart Lung Health, dedicated prostate MRI radiologists that will report those using AI as well. Yeah, which it's the first time I've seen it. When the radiologist brought the laptop in and said, "This is how we do it," it's like, whoa, okay, really quick. You're talking yourself out of a job.
I think your both scanners were upgraded not long ago. Is that correct? The 1.5 and the 3 Tesla to get some smart speed and all the AI.
Yeah, I mean the scanners were put in the back end of 2017.
Okay.
We had they're both Philips. We got a 310 and a 1.5. We had them upgraded last year. Yeah. So we got release, I think it's release 11.2 now, which incorporates compressed sense AI, which is good for certain things and not so good for other things.
As everything. It's everything in MRI is a balance.
Philips will sell it to you as the all-seeing guy and then answer to all your problems, but it doesn't always work like that. I find it's really good for MSK stuff. It really brings your scan time down. You know, you can do a knee in 7 or 8 minutes, a full knee.
A full knee, of course. Yeah.
And it brings some of the breath holds down. But for things like cardiac, where your breath holds are 6 or 7 seconds, if you bring it down to 4 or 5 seconds, it doesn't really make
much of a difference.
Much of a difference. And we kind of find that our images are actually better if we turn that off and go back to just compressed sense.
Oh, that's interesting.
That's an interesting point of view. Actually.
It has its benefits.
It's not the first time that I hear this. Yeah. So I think, that it might require like further perhaps discussion regarding this.
I think everyone's jumped on the boat of, they always sell it to you that it's your systems are going to be quicker and your image quality is going to be better. But in practice, you kind of find out as radiographers that it's not always the same. And you end up reverting back slightly. You use it for some things and not for others.
Matt, can I ask you something? You mentioned all of the scans are without contrast, right? So I guess for like a body part like prostate, DWI plays a key role, right? Because I mean, like another topic that's kind of like is becoming quite important is even doing like a biparametric prostate or do like multiparametric prostate. So I think in this case, you're kind of showing that just with the DWI and the morphological sequence of the IRST2.
We'll do a multi-B.
Yeah.
And we'll do a higher B value.
Yeah.
At the moment. So a B2000 or a B1600 as well as the multi-B, which I think is 50, 100 and 500 off the top of my head. Yeah. But it's we don't give contrast. I think as a health assessment it will point to the fact that there might be something wrong with the prostate alongside things like the blood results,
of course,
and the ultrasound. It's all
I find it quite interesting actually, because there are more and more patients that will need in the future to access perhaps a prostate scan even as a form of screening.
But I think
it's number one cancer in UK.
Yeah, exactly.
As years progress, things will get quicker, and it won't be long before prostate screening will be introduced, the same as it is for breast, cervical.
You think
screening.
This is going to happen?
I think it will as things progress. As you need to do less sequences as a screening system, and then it will then go to the multiparametric where they'll do detailed MRI prostate with contrast.
I saw an article, it was this month actually, saying the non-predictive value of the B and the M multiparametric and the B parametric is basically similar. So probably there's not a need to every single center to be running a multiparametric protocol when you're just looking for major problems. So it makes total sense that you're using the other one. alongside the blood tests and the ultrasounds and everything else.
The advantage that we have is that that we've got the other things. We've got time with our clients or the patients to go through, which adds to the picture. And actually, a lot of so far with any abnormal findings that we had with the prostate, they've gone mostly not to a multiparametric next. Actually, they've gone straight from our bioparametric to biopsy, which is actually a better pathway, probably a better journey for people. There will always be situations where there's a little bit of difficulty maybe in fully interpreting, so multiparametric would be the best next step. But actually, from conversations with the uroradiologists that we work with, and also with one of the big urologists within London as well, they have said that actually a lot of the time you can go from the bioparametric to you've been confident to go from that to the biopsy rather than having the extra stage of the multiparametric.
It's good that you're touching on the biopsy point, because it's also one of the pushbacks with the whole body scan thing, because people talk about that there's a lot of false positives and a lot of false negatives, so I will ask you about that either. But this biopsy thing, is it a big thing with your protocol? Do you really need to biopsy a lot of your patients after they have their dedicated scans? Let's say you have a cardiac scan, you find something there, the bloods actually match what you're looking at. Do you still go for a biopsy? Is it common to happen with your protocol? Or?
So it's a little bit difficult to say, because obviously we're trying to identify if there's a problem or identify something there. If there is something unusual, then we refer on to specialists, and especially within London, we've got
within your clinic or
not
outside?
within our clinic, outside. Okay. So that in some ways is so it's not within our clinic, is outside of our clinic, but we have very good relationships with specialists in different areas, and probably the main areas or the big areas that you would see referrals for. We've developed a network over around the last 20 years. So we do get feedback about the outcomes of what we found after the person has been referred, what that shows. I would still say that it's a minority of people that get that have very significant findings. So just it's obviously not easy to give exact numbers,
of course,
but
it's a case by case anyway.
Yeah, it's case by case. And because we're checking so many things and we give advice about different things, some of it doesn't require referrals, but probably half of the people that we see don't need to have any referrals after, and that's from all of our tests, not just talking about MRI.
That's good, because what I was aiming at is how thorough your whole protocol is.
Yeah.
Because if it's not very thorough protocol, you eventually have to, as you said, refer the patient out and do biopsies and do probably more dedicated imaging and all of that. So what you're telling us is basically your protocol is very thorough.
Yeah.
So by the end, do you normally have the answer to give to the patient? If not, you basically direct the patient to a specialist that you have basically a relationship with. Yeah. So you continue that patient journey very smoothly.
Yeah, so exactly. So I think we have a very thorough assessment. Biopsies, if they're needed, but what we want to avoid is unnecessary biopsy or reducing the chances of unnecessary biopsy. And so I think if the combination of what we're doing with imaging, but also the other parts, gives us a better idea of and reduces the number of false positives in that way, and we try to support people as much as possible if they do need to have that referral, which might end up in a biopsy, because we don't want to be generating undue anxiety. So I think that's one of the pitfalls of just going to a clinic, jumping to a scanner that scans your whole body or whatever it's scanning, and then you get a report back with every single small slight abnormality a couple of weeks later without maybe a little bit less feedback. I think we're quite careful in particular, and that's why we involve doctors in that. So we have a radiologist on site that have a consultation with our clients to go through their images, and then they've also got that results consultation that I mentioned with the GP, because there will be lots of things that we find. So certain cysts, for example, which are really common, we can tell our clients that they're there, but we're also very clear to say, well, it has no worrying features, it's completely benign.
Because for a lay person, when you tell them
you don't need you do not need to have any follow-up for this. This is not going to cause a problem.
Yeah.
At the same time, if there is
important,
so I think it's really important, and it's something that personally I say to the clients I see at the beginning of their day, is that we may tell you that there's this cyst or there's this finding, but we'll be extremely clear to you to let you know if it's something significant, if it's something you need to act on, or if it's something that you can completely forget. Because that's the way to try to reduce the anxiety for, in some ways, knowing too much, but not having any context to what that means. So we do our best with our communication, be that with the doctors or with all of the material and actually all the conversation that all of our team has with them on their day of the assessment and actually before, to make it clear that we're not just there to identify every single thing and then tell you that you need to have that assessed by a specialist, and then the extra tests and the extra invasive procedures that someone might need. We're very specific with what we're trying to do. We'll highlight things which we think will be very important, that will have an impact on your health, your quality of life in the future, and support you in how to do that.
I would like to comment this with a little bit of a story. So last year I came across this post, and without mentioning any specific companies, give it like very random. There is Kim Kardashian taking, I don't remember if there's this selfie or like a picture saying, you guys, you should try this MRI scanner, this whole body MRI scanner. I also say funny things about confusing CT, MRI and stuff like that. Anyway, that was pretty funny. But it's also like, I think shed quite a lot of light regarding preventive medicine. But it also, as Sam was mentioning, quite attract a lot of pushback, meaning doctors saying, from one side, it's unethical. Someone say there is a risk of overdiagnosis. We do scans when we don't actually need it. So do you think this, how do you see it? How do you perceive this? Do you think there is like a certain truth behind this, like this reaction? Is it kind of natural? Or do you think just how it was advertised, the whole thing didn't kind of like give credit to the importance of preventive medicine?
So it's a good question. I think it's a combination of all of the things that you've mentioned. So there are definite pitfalls there in terms of doing a whole body or very comprehensive scans. And I think what we try to do is to address all of those as much as possible. Yeah. Now, if you do an MRI like we've mentioned, Matt and I have mentioned, and the body parts that we scan, it may lead to extra investigations for certain things, which might end up to be normal. That's a definite potential. But at the same time, we've seen lots and lots of cases of, give you examples of people that we've scanned where we've picked up things that are very, very significant things, such as certain cancers, kidney cancer, aneurysms, and other things which are really significant that person would never have known unless they came to us or came to somewhere like us to have their scans, and then we're able to get treatment at an early stage where the likelihood of it being successful is much higher. So I think that there's the kind
of like servicing your car. You'll get your car serviced every year, and if there's a small problem, they'll point it out, and then you'll get it fixed. Whereas if you don't get your car serviced and you wait for it to break down, it's going to have a bigger impact. So
absolutely,
I think our assessments, because they're doctor-led, rather than someone just picking up the phone, going in and having a scan with no follow-up, with no guidance or talking about the results that they may or may not find. If there's something wrong, I think we're a bit different to just walking in off the street and I'll have that scan, please.
And at the end of this day, does the patient have like a report in hand about everything they did? And if they do, is that scalable or is that reproducible? Can that patient take that report and, let's say, go to United States or go to Germany or any other country and jump in another clinic that does similar job or something like that? Can they compare it? Is it the report they have in their hand is useful for other doctors to actually progress the medical history, or how does that work?
We get clients that have been elsewhere before and had health assessments, and they will bring their images so we can then the radiologist can compare what they've had done before to what they've had done with us today. The same with their reports. It all adds information to help find out a person's history.
So it allows them to continue with their journey, I guess, in terms of prevention. It's not just a one-stop, you have this, and what we do or what we see is going to be not translatable to what you do in another clinic, be that in the UK or outside. I guess the only thing is that units for certain blood tests will be a little bit different, but you will get exactly the same picture.
The reason I'm asking is because there's a company, I'm going to name it as well, but the protocol they have is so specific that it's not translatable to any other facility. So imagine they have a scan with them, they have this massive protocol, they have the whole report, they come to Preventicum and you can't use it because you can't even read it because it's on their own kind of thing file and you won't be able to see it. So that makes the patient come back to them again for another scan. So my question is more towards that. Does the patient have to come back to you if they want to continue that journey that you're mentioning, or they can pick up your report, go somewhere else,
they're
in another country, let's say?
We leave it very open. I think all of our things are transferable. If someone wanted to go elsewhere afterwards, that other doctor clinic will be able to use what we have, be able to interpret that, be able to replicate it if they want.
Because there's a lot of healthcare tourism anyway. So people, for example, they might come to London because they heard of you and they want to do your protocol and it's awesome. They've done it, but then they move back to their country. Yeah. They might want to do it again there because they can't come to London again. Yeah. So that's why I was asking that question. Because
I don't think there's anything that we do that necessarily we're definitely not on purpose to tie people in so that they have to come to us at regular intervals. Obviously, we recommend that if you are going to have checks, they should be done regularly, but we definitely don't do anything actively to tie people in to us. We very much hope that they do come back to us because of what they can see the benefits from their assessment with us and the service and the care that they've had from the doctors, but if they chose to go elsewhere, they would be able to use that information. And we have, each client has their own portal. So the report it can be a physical report, it can be electronic online reports, online reports. All of their images are there. So they want, and if another clinic requests for transfer of images, especially when we're talking about specialist referrals. So
it can all be IEP.
We IEP. So we're very open and
just have one more question before I pass to you. I know you want to ask something. It's to Matt because all this preventative medicine thing adds a lot of stress to your patients, clients, right? So they come to you already with something in their minds. We know that claustrophobia in UK is around 10% of the population, something like that, according to NHS studies. Do you deal with a lot of people that come to you for their MRIs and they, on top of being claustrophobic, stressed about the results that they might get? How do you deal with that? Is that a common thing?
We're quite fortunate. When we moved to where we are now, because we used to be in Shepherd's Bush, and then we moved to Chancery Lane. Before we moved, I went over to the Philips factory in Essen, to look at their latest scanners and also experience their inbore technology with the ambient lighting. And the first thing I felt was we've got to get that because it's such a benefit to people that are claustrophobic where they basically can see and watch a screen behind them, so they're not looking at the roof of the...
So you have the entertainment system.
We have, well, I mean, most scanners now are wide bore. They've all got fancy lights, but we have the inboard technology as well, so that a client can lie there with the mirror, it's a huge mirror, and watch a screen on the back or watch Netflix.
I think I want to resonate exactly what he said, because when I started actually working on an old Philips scanner, and the rate of was an old Achiever, the rate of cancellations was so high because people were like, "Oh my god, I'm stuck in here." And instead, I actually worked with that scanner you saying, and because of that, because of the light, because of the side, and how large is the bore, because of the entertainment as well,
makes a difference.
The number of cancellations suddenly dropped massively. I mean,
back in the day when I was a student, before we had Sky and the internet, the first MRI scanner I saw, it was closed at the head end. It was a tiny little hole that, unless you were built like a racing snake, you were never going to fit in. It didn't have any lights in it, and it looked awful. Whereas you look at them nowadays, they're wide bores. The contours are smooth. They're in rooms that are well lit. It doesn't look as scary as what it used to 30 years ago. Yeah, it makes a big difference when they walk into an MRI scanner room now and it's well lit, and some of them have got fancy skylights above them. And now when we've got they come in, their biggest worry is what they're going to watch on Netflix.
The only thing that I think as a potential challenge would be the length of the scan time in your case. If you start combining different body parts, despite, I do agree 100% that the entertainment and everything will make it different. But if someone is claustrophobic or suffering a little bit the MRI, it will start to be the brain, it will start to be the whole spine, for instance, the cardiac bit. It start to be kind of like loading up all together.
But we don't, everything's split.
Yeah.
So the brain will take 15 to 20 minutes. Yeah. The cardiac will take 15 minutes. Yeah. If they have an MSK, it might be 10 minutes. But if it's an ankle or a knee, they'll be feet first, so their head's not in. The abdo-pelvic will, again, 15 minutes. So if we break it down into sections for them. If they're really claustrophobic, we'll start with the easy bit, so they can almost acclimatise themselves to the scanner. Rather than putting them straight in, doing their head with their head. They're just going to freak out, whether you've got Netflix or not. So it's about breaking it down and working with the patient to make sure that they're comfortable. And,
you're right.
You've done the first scan, and you can almost see this sense of achievement. Oh, I've done it, I've done that. And then you move on to the next bit.
We always need to think about it when we talk about cardiac MRI in these type of instances. We're talking about, as you said, 15, 20 minutes, because when we start thinking about cardiac MRI in a normal daily practice, we think about 1 hour scan.
Yeah, you've still got a call, you put the call on, they feel it. It's about, we have a bit more time than you would in a hospital. Yeah. We don't have a waiting room full of patients waiting to go on the scanner. And if we know that someone's really claustrophobic, we can sort of structure our day to accommodate them, to make it as easy and as comfortable for them as we can.
Speaking about hospitals, and let's imagine the average NHS patient. I guess, we can be quite honest. I think maybe at the moment, this type of service is for a certain clientele. How do you make it more scalable in the future? Let's say like I'm an average patient in the NHS and I would like one day to have like a full body scan, or like as you do it, guys. How do you think, like, now this depends on country to country, but how do you think this would be possible perhaps in the future to make it more accessible to others as well?
I mean, it's a good question. I think it's tricky to fully answer it because, I mean, I understand that with MRI, the costs involved with machine operating and so on, whether that can be scalable to like on a national level, national service. I think I can't really answer that. Whether AI and developments there and how that may reduce costs, reduce scanning time, that might make it a little bit more practical. Yeah. So I think that's probably something in the future. And I know certain parts of the world and certain countries, there's a big drive with that because of the resources that they have and maybe the population that they have. So I think that's probably what I would see in the future. It's hard for I think Matt or I to really say about how to scale it up because
I do understand
we do operate. We see a certain clientele, as you say. Yeah. Most of and I think an important thing to mention as well is that we don't. Most of the people that come to us are actually not that they're not concerned about their health, but they're quite practical about things. So they're not overly concerned and that's the reason why they want to have the assessment. They just feel like it is when you service your car. They feel that this is just sensible, and they access our services. Generally speaking, they're accessing private services. So we very rarely will refer back to the NHS, so back to an NHS GP. So in that way, I don't think we're using necessarily the nation's resources. So I think that's often a question that gets thrown at us about what happens to people afterwards, and actually, are you just generating a lot of work for the NHS? I think with the type of people that we see, it's a little bit outside of that. But I hope that with what we do and maybe the results that we have, the case studies, this helps with the argument for something similar to what we do. May not be exactly the same, but it gives an idea of the value of some of these preventive.
I think there's still
tests.
a big stigma in terms of preventative medicine. Around the world, it's getting more mainstream with this nutrition and athletes and all of that. It's getting more mainstream, but it's still, I think most of the population are afraid. They're like, oh, I don't want to do a scan. I don't want to find anything that I'm not ready for. So I think there's still that stigma that, if I have something, I go to the doctor.
People's perception.
I think it's changing slightly.
If I push it aside and I don't know about it, it's not there.
Exactly. It's the classic statement. Sometimes it's better not to know. This is what my mother said. Sometimes I don't want to have
Do you feel
MRI
that
scans.
with the patients that come to you, or they are those? I think the cohort of patients that you see are people that are already focused on getting their healthcare in the right track from the get-go, right? So they already have that way of seeing life that I want to get, even if I don't have anything, I want to be better. I have my fat composition to drop. I want my muscle to be built up. So they already go with the focus, or they are mainly looking to see if they have a problem. You probably get both.
We get both. I would say the vast majority of people are there because they just want to know where they stand at the moment, what they can do to try to
Live longer.
To live longer,
Healthier,
live
probably.
healthier longer. So there's a whole.
Most of them come not expecting us to find anything.
Yes, that is it. They're not there.
That tells quite a lot.
Yeah, and actually,
But we do find stuff, and it quite often it's like buses. You'll find one renal carcinoma, and then you'll have a string of them. And I don't understand that at all. But it's happening.
Because you agree with me, timing is crucial. What sometimes, like my mother, my father do ignore with this statement will say, sometimes it's better not to know that timing. The earlier you got like at something like this diagnosed, and then probably the greater will be the probabilities to get it sorted,
I kind of wish my father had done your protocol, because he ignored signs of problem that he had, and eventually had a stroke because of massive aneurysm in his brain. And if he had done this,
if
we
he'd
probably
had a
had
scan a
figured
couple
it
of
out.
years earlier, then
We figured it out. And talking about that aneurysm thing, I was speaking with Gemma, and she was telling me that you used to do this MRI, whole body MRI. What led you to drop that? And
to do the whole body, you had to give contrast.
so you completely
So
dropped doing
when
it.
we stopped, because we used to do MRI colon as well,
Okay.
where we'd fill the bowel with water.
Yeah.
And we'd already given contrast for the late enhancement of the heart. So the way it used to work was we'd do a non-contrast brain, then we'd do a full body MRI from head to toe, which involved 2 contrast injections. So we do like a half here, and then chase it down that way, which was quite clever. It looked really good. And then we do a post-contrast head, like a T1 post-GAD. Then we do the cardiac, and by the time we got to the late enhancement, it would be about 15 minutes post-injection to make it work. And then we do a colon at the end, where we'd fill the bowel with water and then screen. And we found a number of polyps that way. But when we stopped giving contrast because of it was in the press and the worries about residual gadolinium in the brain, then it meant we couldn't do the whole body MRI anymore.
Have you ever?
Not even with just thinking or using just the DWI. That was not even.
We've looked. You can do DWIBs. You can do it. You could do a time of flight from maybe neck down to mid-thigh, but it still takes a lot longer than it does.
Of
if
course,
you're giving contrast.
True.
And I don't think the images are quite as precise as what they are as if we do.
In terms of contrast, there's now studies out there showing that you can even find gadolinium on the tap water. And there's also there's studies on both sides of the game, of course, but there's also studies saying the amounts of gadolinium that you find in the brain are not actually bad for your health, or you can get those amounts without even getting an MRI injection. That made you ever think about going back to the contrast injection?
I mean, we will still give contrast if it's clinically necessary.
Of course.
Yeah. So,
but not in an exploratory way.
Not as a health assessment. We might have patients that come every couple of years, and if we've been open for 20 years, so they might have come to us every year, every year, or 12, 15 times. And if we're giving contrast every single time, it's a risk that you'll. I mean, it's a drug at the end of the day.
I'm not sure, and I might invite people actually back home to comment on this, if there are MHRA guidelines on this, like using contrast in preventive medicine. Have you encountered any of these, like any specific guidelines say you can use contrast in like a preventive
No, the guidance for contrast is based on their kidney function.
Yeah.
So initially we started for clients that were over 60. Yeah. We would have to get
EGFR,
which then was another hurdle we would have to get over before they could come to us and we did their health assessment. They had to have a blood test done, or they would have it done when they got to us, because we do blood tests. But then we'd have to wait for the lab to send it back before we could do their MR. So it's easier for us as radiographers now that we don't give contrast, because we don't have to worry about cannulating them. We don't have to worry about reactions, etc., etc. But we will give contrast if it's clinically necessary.
Came up with this protocol? Is there a joint idea, or as you're saying before, it's led by doctors, so it was built slowly throughout time, or there was someone that just came up and said, okay, this is the protocol that we are doing for this specific case or for that? How did they work?
When we first opened, we had a medical advisory board.
Okay.
So we would look at the key areas that we wanted to cover. Obviously, brain, heart, abdominal and pelvic area.
The main killers.
As it were, specifically in MR, but because we do ultrasound as well, and we do echo, and the Bruce protocol for the treadmill test.
Stress echo.
Stress echo.
It's one of the first in London, I guess. The treadmill.
So not many. Well, I don't think anyone that does something similar to us does stress echocardiogram. There's lots of work around VO2 max, and I think we used to do VO2 max, but
there are things that we've done that we've then stopped doing.
Of course,
you learn on the way.
That's learn on the way, and through consultations with, obviously there's advancements, there's consultations with specialists. So we have, even now we have a consultant cardiologist that works with us, and he's actually the one that reviews all of the images for the stress echocardiogram. Obviously you've got a team of radiologists. We talk about the prostate, worked with urologists, uroradiologists to develop that. And so we're always trying to take advice from the best people, the right people, to make sure that what we're doing is right for now.
So it's an evolving protocol.
It's an evolving protocol, and it's evolving like the world of medicine evolves.
I guess also research plays a key role, there are quite a lot of studies that keep building up, showing, as we were discussing about biparametric prostate. Yeah. So I think things are going to change, and we need to kind of adapt on the way.
Yeah, I mean, just with the prostate transform study is the big one that's happening right now. I think the recruitment is done, it's going to start, and that a lot of that is going to be focused on MRI prostate. Slightly different protocol to what is not a full biparametric. It's a shorter scan, but we'll see what the results of that show. But that will all take quite a few years. But I've had conversations with people involved in that, and see the principles behind why that's being started, and what they hope to see.
I think it's quite nice sound associated with MRI and screening, because we always thought about MRI like long scan. It's like a contraindicated when we think about getting a patient quickly for a screening. So I think it's fantastic to see there is the combination of these two words, the modality that we love personally, and the fact that it's actually very helpful for patients to kind of prevent disease that might kind of be detrimental in the future.
So if you have a patient listening to us today, in a couple of words, how would you, imagine I'm starting as a patient, I'm starting my preventative medicine journey today, right? What's the advice that you give me now? Where to start? How can I find you? Which package should I choose and why should I choose it?
Yeah. So I think that we offer basically 2 different assessments. I think if I'm honest, either of those are extremely detailed. Our top one offers a few more things, but I think just the process of starting your preventive medicine journey is probably the most important thing. Being aware of your health, aware that you want to try to optimize things. I think that's really important, and that's what's really been shown to the earlier you start and the earlier you know about things, the sooner you can actually make some changes and actually more likely to have things which are reversible rather than things which are irreversible and you need to be treated for them, not have them prevented. So I know we've spoken a lot about big things like cancers, for example, that we might be picking up on imaging, but majority of things that we're doing is actually trying to prevent you from even getting to that stage. And that could be through what we could say are simple things like exercise, diets, general lifestyle, sleep, and so on. But they are so important to actually just be having the conversation about, and for people to know what their baseline is. So if it's your first assessment and you want to come to us, it's getting a baseline, because what you might feel about your health, what you might imagine your health to be, things could be as you expect them to be. They could be a lot better than you expected. They might be worse, but it's good to know where you stand, because actually unless you have those objective measures, be that with imaging, with blood tests, you don't fully know where you are, and you can then take control of
You need that
things.
baseline before starting your journey.
You need a baseline, and it's trying to empower you, a person that wants to have an idea about their health, to know about things and then to be able to make change.
So basically you allow the patient to take control of their own health.
Exactly, yeah. It's about empowerment, really. I think it's very easy to stick your head in the sand and just avoid everything. And I can understand why that's done, and there can be times where that might be right for you. But if the time is right for that individual, that they want to know more, and we're careful, obviously, with how we relay information, and we've spoken about how we look into all the different tests and we try to optimize things. We change things all the time and develop and try to make things better and better. But the whole aim is to try to empower you to know about your body, things that you may know, things that might be blind spots to you that we can identify. And hopefully they're just going to be small things. And that's why I said that majority of people don't get any referrals from us at all. That's the vast majority of people, because not that they don't get any advice from us, because I think there's a lot of advice around lifestyle and very specific things that for each individual. But most of the time we're not picking up a renal cancer, an aneurysm, major things. But even if you talk about an aneurysm that causes a stroke, if you have high blood pressure, which is silent, if you have high cholesterol, if you're diabetic, all of those which are often silent but are big risk factors for developing or worsening an aneurysm, then it's one thing about identifying the aneurysm, but if you can prevent it from even developing to a dangerous size in the first place, then you're one step ahead. So I think that's an important thing to remember.
I think we're almost done. Just one question for you, Matt. Last one. We always ask this to everyone. There's here more related to MR. That's why I'm directing that to you've been in MR you've been in MR for so many years. Our question is, why MRI for you? Why you love MRI? Why you've been doing it for so long and not something else?
Attention, because this is the question now.
The question. This is what everyone's been waiting for. Why do I do MRI? I enjoy MRI. I find it fascinating that you can get an image using a magnet and sending RF in, and how it's developed over the years since I've been doing it. From you didn't have that many breadth of different sequences and scans 30 years ago.
Yeah.
It was T1, T2 stir, T2 star maybe, and now you've got this variety of sequences and parameters that you can change that will manipulate your image. And with some of the stuff that we do, that we can produce now with the volume scans, It is veering more towards that beautiful CT image that you can manipulate and subtract areas from.
I love it because we start to have a pattern of answers now. Since we reach a certain episode, I can see there are some recurring themes. The physics, the fact what is possible nowadays, which wasn't possible in the past.
There is magic,
with the software developments, the ability to get much more detailed images in such a short space of time. I could make our scans super, super quick, but the detail wouldn't be as good as what it is with what we produce. So it's always a balance.
It's always a balance.
You don't get something for nothing MRI,
They
but
say
it's
always
developing
a
now where
trade-off.
you're getting a lot for not a lot of time.
Yeah, exactly.
It's just I've done CT. I did CT for a long time. When I did CT, it would take a chest, abdo, pelvis would take 25 minutes. And it was sequential scanning. It was 1 or 2 slices per rotation per breath hold. Whereas now you'll do it in a breath hold. It takes them longer to get changed than it does to do the scan.
That's right.
True.
But you have to invest time in MRI, and it's developing. The software is developing. You've got compressed sense AI, which I think they're kind of slowly getting their head around it. And I think they release it to the market, and then we as radiographers then say, well, I really like this works, but this doesn't quite work. And then they go back and they're always 2 or 3 releases ahead of us.
Yeah.
There's stuff going on at the factories that we won't see for another 3 or 4 years. And that's kind of exciting as well. And I think MRI has never been great for looking at the lungs, but I kind of think that we're not that far away from where
discussed this actually in one of our podcasts.
Where it will be, and that will make a big difference.
Wonderful. I think that was awesome.
Yeah.
Thank you so much.
Thank you so much, because I think this was a topic that everyone, patients as well, would like to know more back home. So
thank you guys.
thank you so much.
Thanks for having us.